Good morning. I'm Dr. Saloni Sinha and I would be presenting a case on concomitant bilateral candida keratitis with dry eye in a HIV seropositive patient. The slides are not moving.
Someone from AV, please help her.
Yeah. So candida keratitis is an opportunistic infection which usually occurs in an already compromised cornea. The abnormal cornea in cases of dry eye syndrome, chronic ulceration, and possibly HIV infection predisposes the eye to candida infection. Our case is that of a 48-year-old male hailing from Andhra Pradesh who presented with complaints of both eye redness, watering discharge, foreign body sensation, and diminution of vision since 1 month. He gave us a history of exposure to some chemical fumes at his workplace 1 month back, details of which were not known, and he was diagnosed with bilateral toxic keratitis elsewhere 4 days back and was on early steroids, antibiotics, and lubricants. He was also a diagnosed case of HIV with CD4 count of 270 and was on antiretroviral therapy since 15 years. On examination, his visual acuity was counting finger 1 meter in the right eye and counting finger close to face in left eye. Both eyes showed meibomitis. His cornea in the right eye showed epithelial defect measuring approximately 9 into 8 mm with multiple whitish infiltrate, while that in left eye again showed epithelial defect measuring 7 into 5 mm with multiple whitish infiltrate, and also corneal stromal edema with DM folds. So corneal scraping was done in both the eyes and samples were sent for smear and culture examination. His Gram's staining and KOH calcophyr white revealed budding E cell with pseudo-hyphae, and a diagnosis of candida was made, and he was started on early voriconazole, carboxymethyl cellulose, atropine sulfate three times a day, and tablet ketoconazole 200 mg twice daily. And he was called for follow-up in 3 days. In 3 days, the culture report had come, and in the left eye, it grew east, which was subsequently identified as candida. He was improving, so same medication was continued. However, 5 days later, he presented again, and he had developed hypopyon in both his eyes and also a persistent epithelial defect-like picture. So a repeat scraping in this stage was done to rule out any secondary infection, which in left eye revealed gram-positive cocci. So all the previous medications were continued, and he was also started on fortified cefuroxime 5% and ofloxacin 0.3% in both his eyes, and also HPMC gel was added BD. So we can see that his right eye continued to improve over a period of 5 weeks with pinhole visual acuity reaching 20/40. However, that was not the situation in left eye, which kept on worsening. Initially developed thinning, which did not improve after application of cyanoacrylate glue and BCL, and then AMG was planned, but even after that it perforated, and it was taken up for therapeutic penetrating keratoplasty. After therapeutic penetrating keratoplasty, again he developed infiltrate at one side, over which an impending perforation over which TA-BCL was done. The patient is still on follow-up with us, and his infiltrate in left eye is consolidating, and he is doing well as of now. So I would like to conclude by saying that candida keratitis is a vision-threatening opportunistic infection which disproportionately affect a cornea which is compromised by conditions such as dry eye. Despite correct diagnosis and appropriate antifungal therapy, the ocular complications can be devastating, especially in immunocompromised cases, and often require surgical management. Thank you for your attention.
So thanks, and candida is difficult to treat, and one has to give amphotericin B and also a oral antifungal, antimycotic. Let's have some inputs from the audience as well, what they would have done. Agreed, disagree. I see Dr. Sudhakar, I see Dr. Madhukar, Dr. Varsha, so we have many stalwarts with us here. No, it's okay. I mean, that's perfectly understandable, but yeah. So the story is a seropositive with candida infection, keratitis, bilateral, perforation, inferior perforation.
No, why one eye is responding and other eye is deteriorating?
That's infection for us. I think like that's the myriad.
One eye completely dissolved.
And there is also a neurotrophic component.
Yeah.
Might be, there is an underlying systemic immunocompression. So these cases behave in a atypical manner. So we need to be ready with all possible modalities over here.
CD4 count last time when he presented, it was done in November 2022.
Can we have our slides back up, please?
And it was 270. Then again in June it was repeated, and it improved to 1000. So twice it was. He has been following up with us for last 5 months. So
primary immune system is not working. Yeah. Maybe we should have used amphotericin B in the starting because voriconazole.
There were few studies which showed that voriconazole works as effective as amphotericin B with less surface toxicity.
Yeah, but the mechanism is different. Amphotericin acts by creating a pores in the membrane, and voriconazole is inhibiting the new formation. So already whatever organism fungus is there, it will not act on that. Combining them. If it, yeah.
Yes. Thank you.
Thank you, Saloni.